Ladies and gentlemen all over the world, welcome with our apologies for the little bit difficult technical start, but we are there and I think we have a wonderful panel. I would like to suggest that we just start an introduction with asking the panelists to just present themselves and in 2-3 sentences say when they are confronted with, with the topic of this meeting, which is of course about integrating medicine and public health. What is the things that the first ideas that come up in their mind, and it may be challenges, it may be something positive, it may be questions. So let me start with Klaus. Present yourself and then go ahead.
Thank you, Jan. So I work as a family physician in a rural sub-district of the Western Cape in South Africa, where I work with a team of primary care doctors and nursing professionals, and as well as allied health workers, and we provide first contact care as well as so referred care from primary care nurses who refer from the clinics to the district hospital, and so on a day-to-day basis I see the full spectrum of patients from children to the elderly, from chronic care to acute care, even a bit of in-hospital inpatient management and theatre care for maternal and child care, cesarean sections and so forth. So so we work quite close in the community in a sense that the patients that come through the door of either the clinic or the emergency center or the outpatients, they share with us the same community space. So we live in the same area, and we are aware of all the different social determinants, because when one moves from, I do on Tuesdays and Wednesdays, I'm out at the clinics, and then I go to see patients in the different areas of the community. Unfortunately, as with all places, probably the socioeconomic layers are evident from where you go. So one goes into the poorer communities, one sees patients there, one sees the affluent population. Some of them also present to us, but most of them make use of the private health care services. So when one thinks about working interprofessional, so I definitely see that we work on each Tuesday morning. We have a stewardship road round with a pharmacist, a nursing professional, and myself walking through the wards. But seeing the social determinants, and especially I think that's the lens that public health gives you, is we see the community around us, and also on at least every quarter we look at the statistics of our sub-district to see what are the key indicators for maternal and child health, chronic diseases, inpatient care, and then one gets an idea of what is the burden of health disease in our community that we serve. But also directly, when I work in the middle of the night on a Saturday night, I see the evidence of alcohol and violence, interpersonal violence, coupled with again maternal and child health care all together. So on a day-to-day basis, I think it is quite a mixed spectrum of seeing the good and the bad and the ugly of what determines the health of our community.
Yeah, I think this was really giving us a nice picture of how you reconcile, and your life is integrating, your job is integrating the two dimensions. You are in the community, you have the clinical work and the individual people, but at the same time you see all the determinants and you look at them at the population level. I think this is an interesting way of practicing. And on the one hand, I think it helps you to give a new dimension to the individual encounter. And on the other hand, it gives a perspective to the changes that are needed at the population level. So thank you for that, and we are going to come back to that. May I now invite Rob to answer the same question. So just present yourself and tell us a little bit about what for you this integration means between medicine on the one hand and public health, population orientation on the other hand, please.
Good morning, everyone. Well, I also work as a family physician, a primary care physician in a community clinic, CLC, where it's also in a group setting. That's in an urban environment in Montreal. I've also worked for quite remote communities, and I continue to do some public health work with some Indigenous communities in Quebec. So I could mirror many of the comments that were just made around sort of exposure and understanding to the sort of social environments and social determinants in both urban and rural settings where I've worked. I find it a bit of a challenge when I think of my mandate. So working in a more remote or well-defined communities, I found it easier to sort of intervene or discuss around upstream determinants and the social environments that determine health. In complex urban environments where there's overlapping mandates or overlapping systems, where we have sort of a responsibility to a group of patients within a community, but there's other overlapping services that are also providing services in that community. I find that a much more complex environment in which to intervene, I guess would be my comment.
I think that's very important, because this complexity, I think, is really at the heart of what many healthcare professionals, certainly when they are active in primary care in the communities, today are facing. The complexity of all problems that are interfering, the different layers, as Klaus said, and how you try then to deal with that. And I think this integration is in our daily practice. Let's ask Stefan to present himself and ask him how for him, medicine and population health, individual and population health, medicine and public health is integrated. Stefan, please.
Thank you very much. My name is Stephen Odiwuor from the Jomo Kenyatta University of Agriculture and Technology. My university is located in Kenya, a few kilometers from the capital city, that is Nairobi. And I'm currently a final year Bachelor of Medicine and Bachelor of Surgery student, just having a few weeks to clear my campus. And so as far as the topic of today is concerned, integrating medicine and public health, I will start by maybe saying what our school has done as far as the topic is concerned. Somewhere in second year, as early as second year of study, we are exposed to the community, because public health actually is part of our curriculum, and every student who wishes to practice medicine or to do the Bachelor of Medicine and Bachelor of Surgery course in Kenya has to pass through public health, because the board, the Kenya Medical Practitioners and Dentists Board, actually, when they reviewed their curriculum, they integrated medicine, public health, into the medicine curriculum. And so when we were in second year, we went for our community attachment, where we got involved in a lot of community practices, and also getting to know about public health and appreciating the importance of public health and what it does, what it means, especially when it is integrated into the Bachelor of Medicine and Bachelor of Surgery curriculum. And through that, I've been able to learn a lot of things. First, it taught me about community entry, and actually I also got to learn about various problems that our people in the community, in various communities, actually go through. And we are also able to, through that, I was able to come up with a community initiative called the Early Childhood Development Center Malnutrition Program, which tend to screen children in early childhood development centers for malnutrition, because you find that Kenya is a lower middle income country, and so malnutrition is actually a big issue here. And so getting actually to learn about malnutrition and finding it as a problem actually has a lot of impact as far as the people of Kenya is concerned. And so through that, not only me, other students also who have passed through the same curriculum have also been able to appreciate what public health, integrating medicine into public health can do. Because once you become a doctor or a medical practitioner in Kenya, you'll be able to actually understand what it means, because you were taught public health in school and everything. So the topic, today's topic is actually a very important topic. And I would also like to say that when you look at population health and you look at medicine, marrying the two together and actually forming one curriculum that caters for both actually has a lot of impact as far as patient health is concerned. Because if you're a doctor and you are able to understand the preventive aspects of medicine, which public health tends to tackle, it will be very important. Even it will even guide your management. Actually, you can tell the prevalence of the disease at the community level, and also you can even be able to map the disease epidemiologically and even try to tackle it down at the community level.
I think that this is a very important introduction. You clearly describe the importance of training where you integrate both perspectives, not the one apart from the other, so that you prepare clinicians with a public health mind and public health people with a clinical viewpoint. I think that's a very important thing. Let's check a little bit how that works in other curricula. May I ask Vishnu how in your curriculum that was integrated, or was it not integrated, these two dimensions in your training?
Yeah, and so I'm working as the junior medical officer in all the Institute of Medical Sciences Delhi. So I have to say that the experience that I had, like of working with the community in my undergraduate curriculum, like of course it was actually a part of our curriculum, and we were actually exposed to, like, you know, identifying the problems in the community and to reaching out to them, organizing health talks, health camps. So what we were exposed to when I was a student and what I'm actually experiencing now as a healthcare professional, it's kind of two different contexts. So that is how I actually got sort of interested in the topic. Like, you know, when I studied everything, like it was more like we prepare like a 1 week schedule. Like we go out to the community, we understand their problems, we do focus group discussions, and at the end of that we do involve the local self-government officials as well as the health workers. But now when I actually moved to a different state, I studied in Kerala and now I'm working in Delhi. So when I moved to a different state, and now when I actually start interacting with the people, I find that what I learned is actually what is different from what is actually there in practice. Like I'm working in a vaccine project, and like every day I'll be interacting with all the TB patients. So even though we have actually tried so much to sort of bring down the incidence of TB, and we are actually trying our best to make sure that there is sort of TB free, even though the RNTP program is working well, I have to say that it's not just a factor like, you know, you're giving medicine to the people and you're telling them, okay, fine, you can take this for 6 months. It is not just what I understand. Every day I have people coming to me, you know, they find it difficult to come to the dot center because transportation is the problem. Level is the problem. So even if they are sort of like, you know, even if they are like, no, these are the factors which actually make them sort of non-adherence to the medication. And this is why I feel that it's sort of important to integrate both. It's not just making a patient-centered approach. We should always take it from a population health approach.
I think that's very clear. And what I think as the common denominator out of these three contributions is what is so important in the population approach is to look at the social determinants, because that is what influences directly the way we are going to deal with the health problems, the way the problems are presented, but also sometimes the access people will have. Let's think about medication and this kind of things. Jean-Pierre Unguer, this is a man with a lot of expertise all over the world in health systems. Jean-Pierre, you have been informed and confronted quite often with the issue of, well, on the one hand, the population approach and the individual approach, and the challenge to reconcile that. So, Jean-Pierre, can you bring us into how did you, looking back at your career, see this integration or non-integration, and how this bridge should be made or could be made between, on the one hand, the individual approach to patients and the population health approach?
I'm a professor of public health, a public health physician in the Institute of Tropical Medicine in Antwerp, and I've been working during 40 years in Asia, Latin America, Middle East, and Africa. And at this stage, I'm sort of making some wrap up of my career. And to answer your question, Jan, I would say that amongst the many social determinants that I've been addressing, that are determining the health problems of the people that physicians meet, I would say that I concentrated on one of these determinants, which for me is very important, and which is access to healthcare systems, access to the full array of healthcare services, how to improve care quality, how to improve access to the general practitioner, to the hospital, and say to a universal health system. This was my endeavor. I did try to improve that in different settings and make theory out of practice. I think that any physician can have an opportunity to have an impact not only on his consultation room or his or her operation theater, but on the organization of the entire health system. For instance, with the continuous medical education, improving coordination between first line and hospitals, GPs and specialists, interdisciplinary coordination, etc. So that's basically my specific perspective in this question.
Yeah, thank you very much. I think this is very helpful to really put the scene clearly. Just to this topic, David, can you just present shortly yourself and then say, well, what in your view are the opportunities when you integrate public health and individual patient care, what we call medicine traditionally? What are opportunities, and also what are the difficulties? What are the threats? Could you just elaborate a little bit on that?
Yes. First of all, hello from Canada. I'm sorry, my camera's not working. Probably for the better. It's still quite early here. Nice to see everyone. I'm an associate professor of family medicine at the University of Ottawa, and I have some experience working overseas, especially in Africa. So my medical training did tackle public health, but on a very theoretical basis. Once I moved into residency, one had to seek out some opportunities in public health oneself to really get the practical experiences. And I would say until today, even though there's much writing about the importance of merging the two, they still, in Canada, work very much in silos. I'll give you one example. We're involved in a homelessness guideline project right now. And it's really quite fascinating how we have to change the messaging depending on whether we're writing for the primary care practitioner or the public health, more system level thinkers. And it's really a pity. We're really trying to tackle why it's this way. Why can't we write more common messaging? Part of the answer, of course, is that everyone is so busy and has difficulty thinking outside of their immediate contexts. In Canada, we don't have a geographic catchment-based system. And so it makes it difficult to even know, if you are to think beyond your context, your immediate context, how far do you go? I have patients who travel an hour or two to see me just because of the silliness of the system. You know, so is that my context, or should we be moving more towards a really community-oriented system, which some countries do very well, and that would help break down some of these silos. That's my immediate contribution.
Thank you very much for that. Dr. Brahm Marjadi?
Yes, hello.
Okay, yes.
I teach social determinants of health in this School of Medicine. And I always find it interesting that for some perspective, teaching public health to medical students. First of all, I was actually trained in Indonesia. And in Indonesia, public health is always part of the curriculum, one of the major 5 clinical rotations in the clinical years in medical school. But I noticed that in Australia, people don't call it public health when they are in School of Medicine. They call it everything else, but they don't call it public health. They call it community health in the community or whatever. The term public health in Australia seems to be a very specific silo, which is seen as completely detached from clinical medicine. And so that's my first observation, and one of the biggest challenges, because even when I send my students out to public health services and health promotion, that delineation between medicine and public health is very, very prominent. Like, we are public health people, you are medical students, here we are sharing what we do with you, rather than seeing it as interrelated, as the way that I was trained in Indonesia. The second thing, that it's always a dance, I think, between clinical medicine and public health, in the sense that public health is supposed to be thinking about the whole population, but there is a compromise where we talk about social determinants of health of individual patients that come through the door, because that is a more palatable way of teaching public health to medical students. Once we start saying to medical students that they have to, advocate for the community, they have to address poverty, homelessness, that sort of structural problems, then they started saying, this is not me. I want to become a doctor. I don't want to do all those things. Public health people do that, not me. And I can only say that because that's how I thought when I was a medical student learning public health. I remember I used to say, I used to say to my classmates, there is no way I'm going to ever go into public health, because I want to cure people. I don't want to build latrines. And now, fast forward 20 years later, 25 years later, I have my postgraduate degrees in public health, and I'm teaching public health to medical students. So that's a little bit of perspective that I would like to share with everybody. Thank you.
Thank you. And I think it's interesting, because I think that in many countries in the world, public health and clinical medicine are two distinct entities that are not talking too much to one to the other. They are, somebody called it, it's different languages, like David said, and there is the silo kind of mentality. And that's of course quite strange, because at the end of the day, we both are taking care of people. The ones at the population level, the other at the individual level.
Hi to everybody. I am originally from Puerto Rico, but I studied in the Dominican Republic for almost 6 years. I recently graduated, and while I was living there, I have the opportunity to work in different medical missions and help in different communities. And what I could observe of the lack of opportunities was the need for more sexual health, because we had a lot of women having like abortions unplanned, and a lot of them were dying because of it. And also hypertension is a crisis there, I think in all the world, but it's really more seen there. And also I had the opportunity to contrast that with Honduras, because I visited Honduras for also a medical mission with a group, and the community was really far from the regional hospital, but still I could observe that those people were like healthier than the ones that had medical access here in the Dominican Republic. So that caught my attention in a way that I think that sometimes even when we don't have a hospital, we can have health. And I think that that's important to notice. Thank you.
Thank you very much to emphasize your experience in this. Nick, do you want to add something? If not, I would like to invite James to contribute. As you all know, James originally wrote the first position paper of the Network Towards Unity for Health in the previous century on integration of public health and medicine. James Goffin, can you add your view on it, and especially did you come across after 20, 30, 40 years thinking and working on this two dimensions, can you help us a little bit to understand how we can build bridges? Because I understand from the different interventions that it's so important that we find ways to build the bridges, although there are still, well, big distances to overcome.
I'm thinking how to contribute to the discussion as far as we are already half an hour in this review of different people. I do remember, Jan, that when we started with a task force, and that was in Sicily in 2003, the question was how to move ahead on the integration of medicine. Sorry, we didn't say integration, we say integrating. That means it's a going on medicine and public health in the three dimensions: teaching, learning, practice, and research. And the question is how to deal with all of them, because each one of them has different environment, different question, different interest. But we do know that medicine alone is not able to solve the problems of the health in the community, and public health either, not possible to solve. So the question is how to join based on the options. What are the options? The question of also that we call the catch-22. The medical institution, sorry, the academic institutions said that they are not able to teach too much how to integrate medicine and public health because there are not many or enough practices whether to have the field training area. On the other hand, the health organizations are saying the opposite or the same. Say they cannot try to change their system because there are not enough professionals that have that particular training. So in this catch-22, what should we do? What we did all the time, Jan, as you know, and as you are doing the same in Belgium, is to work through community-oriented primary care, COPC. And that is okay, I agree with you. So as far as we know, this is not prevalent everywhere. No, it's not, but it's prevalent in different places everywhere. So as I said, in Belgium is, in the United Kingdom, in the United States, in South Africa. The person who spoke, I'm sorry, the professional who's a student who spoke from South Africa, I don't know whether relates somewhere with the KwaZulu-Natal experience that is also today present on the integration of both medicine and public health. But there are examples. There are examples with positive results of that. So yes. Can I show something to you?
Now, this is the book by Ryan and others, Community-Oriented Primary Care Health for the 21st Century. And then the Global Community Health by Chaim and Rosa Coffin, The Essentials. Okay, I think these are two very important resources. We will put them on the web. So,
no, the question is, resources are there. No, so how, and I finish with this, I can talk more, but how the network...
We will be short.
Yes. How the network can go ahead with all the people who belong to the network or who eventually in the future will, how they can contribute to the understanding of the need and the option and the feasibility of integrating medicine and public health. And I
think this is a great contribution, Chaim. Thank you for that. And it brings us also to the second part of this, that's really looking for solutions. And I think the expertise, and it all started in the 40s in the previous century with the experience of Sidney and Emily Clark, in the Polela community in South Africa that looked not only at their individual patients, but also at the different determinants, the prevalence of conditions and how they could address the upstream causes of ill health. I think that this community-oriented primary care approach is absolutely one way. Actually, we could put it in practice. There are a lot of examples. We did it in our own community. It worked wonderfully, looking at different problems and always taking something that happened in the daily consultation as a starting point of our activity. And then see what was the prevalence, what were the determinants involving the local community, and try to find out how we can address the upstream causes in order to be preventive and avoid. A simple example was the case of a scholar that was severely hit because we had a very unsafe road in front of the community health center. Well, of course, we could run out and call for an ambulance, but we did that. But then we started with the local community, and 500 people participated in make a new design for the road, only 2 instead of 4 tracks, and make it much more safer. And that was implemented after 5 years. And never after that, there were severe accidents. So then you really go to the upstream causes, and you try to really make sure that things are no more happening the way they did before, and that you try to avoid as much as possible the determinants. That's just one example. But also for our students now in the second year of the undergraduate curriculum, we engage them in visiting a family living in poverty and bringing those stories together at community level, confronting that with data, and then making a kind of community diagnosis and going for interventions. And in one of the previous contributions that we made, I gave in extension examples. You can look at it. It's on the website of the Network to Unity for Health. But I would like now to invite other people to look how we can take advantage of this kind of approaches at the level of the community, but also at the level of our health system. Maybe we should organize primary care in a kind of primary care zones where people are accountable for 100,000 people, more or less, and then you can organize your practices and see how you can make a community diagnosis from your practices on to make sure that you find the determinants that can be addressed to improve the health of a certain population. And that links both the curative sector to, on the one hand, with the public health sector on the other hand. But that's just an example that we are trying to put into practice actually in Flanders, in Belgium, to make that happen.
So, Jean, I can bring something in from the
yes, please go ahead. Yes.
Symposium. So many of your colleagues have really been having this conversation about not just public health or medicine, but how do you bring the community into this perspective? And they're really thinking about these community workers, and then many names in many different countries. But it really gets to the question of accreditation or certification, and what do they need to be trained on? So there's an extension of the medical team that has far reaches out besides the medical systems or so. And I think it's really the only thing they're thinking about is really what training they need to have, and then how do you accredit that so they can be part of that team and part of the conversations. And that brings in this a huge workforce that has not necessarily been tapped into because they're not trained. And I'd love to hear more about that, because that's a conversation going on somewhere else.
Okay, so you bring in also the need for appropriate training and accrediting institutions according to the fact whether or not they integrate in their programs these 2 dimensions. I think it's an excellent point. Who else wants now to join? Jean-Pierre, you want to comment on this?
To say that as far as the medicine public health integration is concerned, 2 angles can be viewed. On the one hand, from public health, for instance, there is a need to address individual care, and from medicine, individual healthcare delivery, there is a need for embarking in community medicine. And these are 2 different perspectives. In Belgium in particular, the preventive medicine tends to be demedicalized. And I think that this is extremely preoccupying, because the integration between activities such as under 5 clinics, antenatal care, detection of metabolic diseases and so forth is threatened by the demedicalization of public health and preventive medicine. That's from the public health angle. And in the activities of individual doctors, the difficulty is that externalities with community impact from individual care delivery are not reimbursed by the social security. So that the integration in many countries, not only in Belgium, is really threatened by the way healthcare financing is conceived and by the way public health interventions are conceived.
Thank you very much. I now will invite everybody just to give this one idea that can help us forward on this pathway to formulate that. I will ask now David to take the floor.
Yeah, those last points were fascinating. I'm reflecting in Canada, we have limited opportunities to even interact with our public health colleagues and vice versa. So what are the fora necessary to permit more regular interaction? When I get a phone call from a public health professional or when I call a public health professional, it's always extremely helpful and collegial, but how do we encourage more regular contact is something I'm reflecting on.
Okay, and could that better work if we try to organize an accountability for the population also at the level of care practitioners in the curative sector, so that you define, well, which people you are accountable for as a care provider, and then take that population also from the perspective of a public health approach together with the public health services. Would that be a way forward?
Yeah, I agree that kind of geographic thinking would be a way forward, at least in my context. And you know, with the advent of family health teams and healthcare teams, we should really be looking at asking our public health colleagues to join our clinical teams, just like we've asked pharmacists and other professionals, social workers. Why not? This is not, as far as I know, this hasn't happened in Canada, but what a fascinating idea.
Okay, great. Stefan, what do you think in Kenya? How could this integration be further fostered?
I think that what I'm thinking about actually is how the public health units can be included in the medicine curriculum, both nationally and internationally. For example, if you look at the United States medical licensing exam that students do to become international medical graduates, it has no public health aspect. So most people who become doctors actually don't get exposed to actually public health units. So they grow up knowing that they'll be at the curative end of the disease. But if the system is changed, actually it's not such that the United States medical licensing examination, the public health aspect is broad and students get examined on it. They'll grow up knowing that health starts at the community. But you see, the system that is currently in place maybe teaches doctors that you are only at the end of the disease, the curative aspect. You don't care about the preventive. So many people who study to become international medical graduates actually just know clinical skills and they know the anatomy, the physiology, and everything. So if that system could be changed, I think many doctors will know that actually public health is very important, and they will actually be able to embrace it and actually get involved in a lot of community work and everything. So the national examinations and the international examinations, I think, they should be changed and public health aspect included in those exams.
Yeah, that's a very clear statement.
Yes.
Yeah, thank you. Klaus, from your expertise, how could we bridge the gap between public health on the one hand and our clinical daily service on the other hand?
Yes, I'm contemplating, because in a way, I think one has to, in a way, be tuned in with daily clinical work, or at least weekly contact. But one also has to be attuned into what the more macro level data on global health and of the local population is like. So there's a marriage between what one experienced firsthand, and that one is also involved with reviewing the local systems or local communities' health data and hopefully make an impact and in the decision-making processes about planning. Because I think someone said also the whole issue is about access to quality healthcare, and I think if one just focusing on the clinical side, the day-to-day primary care, one is so your mind is just occupied at focusing on the issue at hand here, the short-term issue. But I think one has to have that bigger perspective, that take a step back and look at, but are we actually ensuring access to especially the vulnerable groups within our community? And I think that if one asks that question, but one has to get the community's voice into this discussion. And I think that's a challenge for us, because I think we are quite good at having the clinicians involved. We are good at getting the public health experts involved in health management teams, having a geographic custodian perspective. So we take custodianships for this community, but the community's voice is not always represented.
Yeah.
And I think that's where the students, I think, can also come in, because I think they are often that connection with the realities of living in a community.
Yeah. So I heard two things. On the one hand, try to find the way to integrate a helicopter perspective so that you look really from another angle. And on the other hand, very important to involve the local people. Participation and communities can be one of the facilitating groups in enhancing that participation. Thank you. Rob, can you give some final reflections in how to improve the situation? Thanks, Klaus. Yes, Rob?
I think at McGill we have a partnership with community organizations for medical students in their second year that makes an exposure to sort of social supports provided by community members is something very real and experiential for students. I think that is one way of getting sort of the medical community or medical students to think about public health from more than an epidemiological perspective. A more radical idea I also have that I was thinking of during this discussion is, I think we're very separated into different disciplines in medicine, and I'd like to see a little bit of more flexibility in movement between primary care and public health. I know in many communities, people sort of develop an interest over time, and there's a lot of barriers that prevent movement between primary care and public health in sort of the licensing and systems in Canada and Quebec.
Yes, so you say start early, second year already, to bring this contact with the community. And on the other hand, try to find ways to bring the careers more close together so that it is not the one or the other, but there is integration. Thank you. Brahm Marjadi, can you from Australia add something to that late in the evening?
Yes, just very quickly. Recently, I spoke with a public health practitioner, a professional, who told me that she did one clinical subject in her whole public health training, and she hated it because she didn't see public health as having anything to do with the clinical side. So I think we need to improve both the medical curriculum as well as the public health curriculum to bring, I mean, it takes two to tango. Right. Number two, I think we should really capitalize on the integrated curriculum in medicine. So public health should never be taught as a separate subject, but it should be really embedded into every single, in my university, we put public health aspects into every single problem-based learning scenario that we give to the students, and also in all the online modules. So we just throw in, you know, bits and pieces here and there, because the idea is to embed it into everything so that the student doesn't see it as something separate. That's
so, integration is extremely important on the one hand, and second, it should be fun, because if not, you will not attract students for that perspective. I think that's important.
We actually put public health components into OSCE.
Yeah, of course. Very good integration, yes. Cathy, Puto, do we have you? No? Angelica, are you still there?
Yes.
Can you give us your final view from Latin America on what can we do to improve better integration between clinical care to individuals and public health approaches?
Yes, what I'm going to add, beside
Shortly.
the excellent ideas that all of you have brought, I think that we have tried a model in Honduras with the group I participated, and the approach is basically to integrate the regional doctors and also the volunteers from the community. What we do is we try to go to the same area all the time and follow up on those patients. So we're not moving around and giving just medication to people. So if you follow up on a community and you work with the doctors there, and the volunteers on the communities, you have people telling you what they need, their specific needs, and how you can bring them new resources and maybe move them to regional hospitals and get them surgery or whatever they need. So I think working with volunteers and adding them into the whole setting of medicine and the doctors there, it's a good way to start.
That's also a great contribution and inspiring in the way we can build on. I would like now to end up with really bridging two generations. Vishnu, you are the future. You are the president, chair of SNO, the Student Network Organization. So in one short minute, what would be your aspiration for the future? And then I will ask Jaime to give a final reflection also in last final minute, because then I think our time is over. So first of all, Vishnu, if you look at the future, what would be the perspective we have to strive for?
Yeah, okay. So because all the students, be it medical, be it dental, or be it students of allied health sciences, all of them in their undergraduate period, they are actually exposed to all the community awareness or the community orientation programs. So the primary, like they are exposed to the primary tier of health system in India, then the secondary tier and the tertiary care. So what actually makes the difference is that once they pass out, once they're out of the undergraduate period, the government actually sort of makes it in a way that public health is not an attractive career choice in India. For example, when it comes to the postgraduate examination, for example, all my friends and everyone, nobody actually wishes to opt a career in public health. Everyone would actually want to go after clinical health, clinical medicine, like, unless and until you want to do, like, you want to end up as a professor in a medical college, people don't usually opt community medicine as a career choice. And public health as such is not included in the postgraduate curriculum of India. It is actually even a separate course. So I have to say that if you actually need to sort of bring this into the mainstream, it is sort of important to sort of project this as something which is really important. Like, even if people actually want to pursue their career, thinking about the future career prospects, thinking about the prospects which other options can actually sort of offer to them, many of them are actually sort of decided, like, why should I actually choose a career in public health? What am I actually going to do? My people who are actually working in different, taking different branches, they're earning better than me. So I think this is something where we actually need to sort of target. And for this, I think it's important that, we need to sort of mobilize the student community. It's better to sort of give them an orientation, like the community-oriented primary care program. Like, it is not actually a part of a curricula in many areas. Okay, so I think the first thing that we need to target is, like, we need to get a sort of student community. We need to sort of develop an integrated framework for that. We need to make them realize the importance of this. Just because the government or the country is not supporting it doesn't mean that the student actually shouldn't, even if they're interested, they shouldn't actually get sort of disheartened and they shouldn't take it as a career. I think that is what we need to actually sort of focus on this.
Thank you very much. That's a clear message. Jaime, your last wise final reflection, and then we will close this session. Jaime.
What responsibility. First of all, I think very, very nice that we had this option of the network of youth moderating this session and taking into account all these ideas. I will add another element.
Yes.
This takes time. We started in 1987 in Spain, training family physicians that were called family and community physicians, but they didn't know anything about community. We started throughout the years. by workshop of 5 days, 40 hours, we trained 500 people. And in 2015, the Generalitat of Catalonia decided to start a project of community health for the whole region. And my end, in the article that you were part of it, that was published in June last year in Health Policy, in where 34 countries were analyzed by GPs on their community orientation, there appeared Spain as one of those who are really feeling that they are doing this. So it takes time, but we should go ahead. Good luck.
Thank you so much, and I think that's the message. We have brought together here people from all the continents, people from all the generations, to reflect on how to bring together, on the one hand, this clinical care, and on the other hand, this population perspective. Thanks for joining us, and I give the final handover now to Nick Torres to finalize this session. Thank you all for being with us.
Well, just thank you, everyone. We appreciate everybody joining us. And, the next one will be really about focusing on migrants or refugees, looking at a different approach for that. But I hope you join us weekly. And, thank you to John for a great moderation. Thank you for Vishnu and Stephen for joining us. You were the ones that were prepared. And thanks for everybody just for your contributions. And again, thanks on behalf of the network.
Bye-bye.
Bye-bye.
Bye-bye.